morning. Thank you. The goal of my presentation is to share with you our clinical technique and imaging technique of targeting for pallidotomies. Targeting for Globus Pallidus interna in functional neurosurgery has mainly utilized indirect targeting methods. These include either consensus-based coordinates that are derived from AC-PC distances, most often in relationship with mid-commissural point, or atlas-based targeting using deformable atlases. While this practice is clinically widespread both in DBS literature as well as in focus ultrasound surgery, this has some serious disadvantages and drawbacks. Most importantly, Globus Pallidus interna in humans could range anywhere from 1600 to 2200 millimeter cube in terms of its volume, and therefore standard coordinates that are used do not take into account of this inter-individual variability in structure and location of GPI. GPI may also be anatomically abnormal. Very frequently in advanced Parkinson's disease, patients may have atrophy or even lacunar infarctions that are accumulated within GPI. While direct targeting of GPI would be desirable, it has been hindered because of poor contrast and poor spatial resolution of T1 and T2 weighted images. As you can see on sagittal T1 image on the left and T2 weighted image on the right, you can see that there's a good contrast between the striatum and Globus Pallidus on these T1 and T2 weighted images. However, it is very difficult to discern the margins of GPI, especially where it contacts the internal capsule, a very critical structure for treatment of Parkinson's disease using focus ultrasound telemotomy. About 3 years ago, we came across this sequence, fast gray matter T1 inversion recovery sequence, and since then we've adopted this in most of our focus ultrasound procedures. Essentially speaking, what this technique does is it annuls the white matter and using a 180-degree pre-pulse and 400 millisecond inversion sequence. And when you do that, you can see tremendously good contrast between basal ganglia, which is surrounded by these with white matter radiations. On the right side with blue arrows, you can see the interface of Globus Pallidus with internal capsule, and the yellow arrows demonstrate the medial medullary lamina, which separates the GPE from GPI. So for this study, we utilized our 13 prospectively enrolled patients in PD-002 trial, which were treated at University of Maryland as a part of prospective feasibility study of MR-guided ultrasound for medically refractory dyskinesia symptoms of advanced PD. Along with other sequences, we utilized 3D FGATIR sequences, and we also did deterministic tractography of pyramidal tract. And what we did was we fused the deterministic tractography and overlaid it onto the 3D FGATIR images into 3 planes. These composite images were then imported into MR workstation and used for treatment planning and treatment. We looked at all the pre-op and post-operative images. Two of the neuroradiologists in the study looked at this. Now, as you can see from this image, adequately placed pallidal lesions should involve the posterolateral or motor part of the GPI. And in this location, GPI is in close relationship to internal capsule and pyramidal tract on the medial aspect and posterior aspect, and on the inferior aspect with optic tract. So these structures are relatively at risk during these treatments. And these are the type of composite images that we use for our treatment planning. We tend to be at least 2 millimeters anterior to the pyramidal tract location as determined on this tractography. In terms of results, qualitatively, the two of us, when we looked at these images, in all patients we could identify all margins of GPI and also separated from internal capsule confidently. And in all 13 patients, we saw more than 50% of the length of the medial medullary lamina that separates the GPE from GPI, so thereby providing excellent confidence in targeting the GPI. When objectively measured, the signal contrast amongst the regions of interest, and here what we see on the left side is the contrast between GPI to internal capsule, which is probably the most key and determinant factor for treatment. You can see that FGATIR provides about 2.5 times higher contrast between GPI and internal capsule. Now the contrast between GPI and GPE does not matter because you can see the medial medullary lamina very nicely on these images. This is a patient preoperative imaging study showing at the level of ACPC plane or a little bit below that the pyramidal tract superimposed on the FGATIR images. This is the diffusion weighted image and postoperative day 1 image. You can see how close this lesion could potentially be to the pyramidal tract. So it is really important to protect that from injury during these treatments. In terms of lesion evolution, it's no different than what we've observed with essential tremor treatments. One should, however, keep in mind that the lesions do not tend to be spherical. As my colleague showed earlier, Sigia, the lesions are oriented obliquely in the coronal plane, extending from lateral inferior to medial superior. So frequent switching back and forth between axial and coronal images is really important during the treatment. The lesions tend to grow for a week or so and then stabilize. At approximately 1 month, the edema disappears, and by 6 months, there's marked collapse of the treatment cavity. I don't have detailed clinical data because we are still analyzing it, but in all our patients experience significant improvement in their Part 3 and Part 4 UPDRS scores as well as dystonia scores. We had no serious adverse event or permanent neurologic injury in this cohort of 13 patients. Actually, it's 12 patients because 1 patient dropped out of the study. One of the 12 patients that were followed experienced mild dysarthria immediately following the treatment, which improved to baseline at 3 months follow-up exam. In conclusion, FGATIR is superior to T1 and T2 based methods in demonstrating boundaries of globus pallidus and also demarcating its external and internal segments. Direct image-based targeting of GPI motor territory is safe, reliable, and effective. It can supplement or even potentially eliminate the need for indirect targeting or stereotactic methods. Superimposition of pyramidal tract on FGATIR images may additionally add to the safety of FUS treatments. Thank you.
Thank you, Dr. And this presentation is open for questions.
Very nice talk. I had a quick question for you. Your last statement about the superposition of the DTI, your anatomic images look great. So what additional information is the DTI giving you that you're not able to see, given how clearly delineated the boundary is on your FGATIR images?
That's an excellent question. And I think that the demonstration of the DTI information is really critical in mapping out the pyramidal tract. Even though you can see the internal capsule very nicely on these images, it is our experience that even despite your best effort in adequately treated patients, there is going to be some extension of the lesion into the internal capsules. Now, it doesn't matter if that extension is anterior to the location of the pyramidal tract. In fact, the one patient that I described that had dysarthria, probably there was some extension of the lesion into the internal capsule very close to the pyramidal tract. Fortunately, he didn't suffer a permanent injury because the lesion extension must be minimal. After that case that was early on in our series, we adopted this practice of moving at least 2 millimeters anterior to the pyramidal tract location. So I think it's not only important to look at the axial images, but also the coronal spread of the lesion, because coronally the lesion can definitely get into the internal capsule despite your best efforts. That's because the lesion's shape is ellipsoidal rather than truly spherical.
Thank you. And we'll go on to, we do have one more question, sorry.
Just a comment, because you've shown very nice single inversion recovery technique. We try to use this technique, but you don't see as well the cortico-spinal tract. We don't understand yet well, but with double inversion recovery, you see less well the distinction between the different parts of the globus pallidus, but the cortico-spinal tract comes out better. So this is the difference between the wonderful images you show and the ones that I show with inversion recovery, but double inversion recovery on the cortico-spinal tract.
Certainly, I think, if I were to only choose one, if you say you can either have one or the other, I would say I would rather take the demonstration of GPI and the internal capsule as well as its medial medullary lamina of the GPI. But that's why, in order to compensate for not seeing the cortico-spinal tract well, we superimpose the DTI images.
Yes, in fact, it depends on the setting that you are doing.
Sure.
Okay, thanks.
Thank you.
Okay, thank you.